Morning. We'll just wait for everyone to come in and then we'll get started. Okay, so I think we'll get started. Good morning and welcome. My name's Charlie Pick. I'm one of the tissue viability nurse specialists with Coloplast, and I'm joined by my colleague, Sam Wharton. She's going to be manning the chat today for you. So if you do have any questions at all, please do put them in the chat and Sam will answer them throughout, and we'll have a little bit of a Q&A at the end as well. So I'm just going to share my screen. She says. Sam, can you see that?
Yeah, that's perfect, Charlie.
Brilliant. So welcome to Making Life Easier with the Coloplast three-step approach with regards to leg ulcers. So we're going to talk you through today how to simplify, how to do a simplified approach to wound healing, help you understand the impact and cost of leg ulcers in the UK, gain an overview of the latest leg ulcer recommendations from the National Wound Care Strategy Programme, and then you will leave with the Coloplast three-step approach leg ulcer pathway to support your practice. You will also receive a certificate for attending today and a copy of the publication that I'm going to talk you through towards the end of the presentation. So the epidemiology of leg ulcers in the UK, it's absolutely well recognised that leg ulcers are a result of underlying venous disease and are the most common etiology of leg ulceration. But a 2015 study found that there were at least 730,000 patients with leg ulcers in the UK. Now that's 2015. We're now in 2024, so I would imagine that number has possibly doubled, to be honest. That 730,000 equates to 1.5% of the adult population having a leg ulcer. It's estimated to have increased by around 101% between 2012, 2013 and 2017-18 for venous leg ulcers. And that's the work from Guest that he did evaluating the burden of wounds in the UK. The number of diagnosed venous leg ulcers indicates that 1 in 170 adults have a venous leg ulcer, but we know that there are so many people out there that haven't had a diagnosis, so that number I'm sure is much greater. Leg ulcers are extremely costly to the NHS. They cause a loss of function and they require that long-term care, resulting in a high financial burden. So there's it costs the NHS £1.94 billion to look after patients with venous leg ulcers. There's an average of £7,600 per patient with a venous leg ulcer, and that can increase to £13,500 for unhealed venous leg ulcers. And I would argue that actually those costs are probably considerably more than that. So this is the Coloplast three-step approach, and this is a simple framework to simplifying wound healing. Now, as you can see, there are 3 steps in this. Step 1 is assess, and that is around the holistic assessment of your patient. So you need to holistically assess your patient and their wound to be able to define those treatment objectives. Once you've done a really robust holistic assessment of your patient and the patient's wound, you will move on to step 2, which is preparation. Now, wound preparation is vital to removing those barriers to healing. It helps us to create that optimum healing environment for that patient, and it will help the patient move along that healing trajectory, because that's what we want. We want our patients to heal. We no longer want to just manage our patients with wounds. We want to get them to heal. So once you've done step 2, you might actually go back and reassess your patient and or the patient's wound, because you might be able to see better what's going on in that wound bed. If you've removed some of those barriers, such as slough, necrosis, any debris in that wound bed, you'll be able to see better what's going on. You'll then move on to step 3, which is your treat, and this is around your simplified portfolio of dressings to help you manage a wound of any depth and any stage of healing. Okay, so we'll talk through this a little bit more in depth. So assessment, the aims of wound assessment. Well, wound assessment can help you to identify that cause of the skin breakdown and identify any of those associated risk factors. If we are able to identify any risk factors or the cause of skin breakdown, it helps us to be able to correct or treat that underlying cause. So if you think about your patients that have venous leg ulceration that aren't in compression, we need to think about getting our patients into compression, because we know that that is best practice with managing a patient with venous leg ulcers. It helps you to identify and control any of those wound-related symptoms. So it could help you identify that exudate may be a problem. It could help you identify that maybe odour is a problem, certainly for the patient, and how we can manage and treat those. But we know that wound assessment can be complex, and there are lots of reasons for that. But if you use a simplified wound assessment framework, such as the triangle of wound assessment, that can help you simplify the process. And if you use the Coloplast three-step approach of assess, prepare, treat, that will really help you with that overall picture of your wound and how to help that wound heal. So frequency of wound assessment will really depend on the condition of the patient, the condition of the wound, and the care setting that you are looking after that patient in. But it will also depend on you as the healthcare professional and what your opinion, because your opinion matters, your clinical knowledge will matter. So we would recommend that a holistic wound assessment should be, as a minimum, every 2 weeks in an acute setting, or every 4 weeks within a primary care and community setting, unless that patient's condition changes. If the patient's condition has changed, then you need to repeat that holistic assessment. So this is the triangle of wound assessment that I've just mentioned. It's a holistic wound assessment framework and helps you to assess and manage all areas of the wound. So it's really important that when you do your assessment, you do your holistic assessment of your whole patient, and that's what this circle represents, your whole patient. So you look at their age, lifestyle, comorbidities, mobility, and any other factors such as their socioeconomic factors, where they live, whether they work, etc. And then you'll focus on the wound itself, and you break that down into 3. So you look at your wound bed, your wound edge, and your peri-wound skin. Now, I would say as healthcare professionals, we're very good at looking at wound bed and possibly wound edge, but sometimes we forget about that peri-wound skin, and it's really important that that peri-wound skin is optimized to help on that healing trajectory. So the indicators of underlying venous disease, so deep vein thrombosis, pulmonary embolism, lower limb fractures, family history of venous disease, and varicose veins are all significant in a past medical history of the patient. The indicators of venous disease that you might be able to see on the lower limb are ankle flare, which you can see in this picture. All of these little tiny little veins that you can see is ankle flare, varicose veins in the legs, pigmentation and staining, which again you can see in this picture, this brown staining here, and the lipodermatosclerosis, which is you often see like the hardening of the skin. The risk factors, so medical conditions such as hypertension, chronic edema, hormonal changes, and the arteriovenous fistula. Lifestyle, so obesity, physical inactivity, stress, history of IV drug use, occupation and hobbies, and multiple pregnancies can all help cause venous disease. So the indicators of underlying arterial disease, so the patient will likely have a significant past medical history of cardiovascular problems. They may have had a stroke in the past. They may have had a heart attack, myocardial infarction, or they may suffer with angina. Now, those indicators of arterial disease as that intermittent claudication, so that cramping in the calf muscle, and the patients will be able to tell you almost how many steps that they can take before that they get this intermittent claudication. So they often can only walk short periods. There'll be pain on leg elevation, the extremities will be cold, and it's likely that they could have discoloured toes. They could have thick and slow growing toenails. They can have absent foot pulses, and they may have pale, shiny, hairless skin. So the risk factors, the medical conditions that are risk factors are, again, hypertension, diabetes, rheumatoid arthritis, hyperlipidemia, and hormonal again. The lifestyle is the usual lifestyle factors of smoking, high cholesterol, obesity, physical inactivity, and stress. It doesn't bode well for us working in healthcare, does it? So wound bed assessment. When you are doing your wound bed assessment, you'll be looking at your tissue type, your exudate, and whether or not there's any infection that's there. So the tissue types that you might see on your wound bed are necrotic tissue, so that black, can be brown, can be hard, or sometimes quite soft and boggy. That sloughy tissue generally tends to be yellow, can look quite fibrous sometimes. Your granulation tissue, which is exactly what we want in our wound beds, and then the epithelialization. So that is the tissue when it's starting to migrate across that wound bed and start to close. Your exudate, the volume can be dry, low, medium, or high, and try and use those words to describe the exudate. The consistency can be thin or watery, or it can be thick and purulent, and the colour could be clear, it could be cloudy, purulent, pink, or red. And please try and use those words to describe your exudate, because it really gives the next person a good image in their head of what was going on with that wound when you last saw it. So your infection, your local infection could be increased pain, that erythema, that redness around the wound edges and starting to spread, edema, local warmth, increased exudate, delayed healing, that friable granulation tissue that bleeds really easily, malodor and pocketing. And your spreading or your systemic infection is that increased erythema, that spreading erythema. So it could be that it's starting to travel up the limb. Temperature, abscess or pus formation, your wound will be breaking down. They may have cellulitis. General malaise, so the patient may be feeling sort of flu-like symptoms. They could have a raised white blood cell count and lymphangitis. Your wound edge assessment will look at maceration, dehydration, undermining, and those thickened or rolled edges. So your maceration, you can see, is this white around that wound edge. It means it's very wet, and the tissues are no longer let's start again. The tissue are no longer able to hold any more fluid, so it's become quite soggy and boggy. Undermining, so your wound may look quite small, but actually if you probe underneath, the wound could be sort of twice as big as the opening, and that's your undermining edges. Dehydration, if your wound edges are dehydrated, it makes it very difficult for epithelialization to take place. I like to think of the wound bed as an ice rink. It needs to be moist and wet. If it's not moist and wet, then it will make it difficult for those epithelial edge, cells to migrate across that wound bed. Think about it, if you have an ice rink as a wound bed, it makes it easy for those cells to migrate. If you have a dry wound bed, it's like trying to ice skate across grass. It can be done potentially, but it makes it very difficult. And then you have rolled edges, and rolled edges tend to show you a chronicity of that wound, and often will need surgery to remove these and start afresh. And then you have your peri-wound assessment, and this will look at, again, maceration, excoriation, your dry skin, hyperkeratosis, callus, and eczema. And as you can see in the pictures here, your maceration has caused problems at your wound edge, but also on that peri-wound skin, because the exudate hasn't been managed by the dressings that are being used. Excoriations, that dry, itchy skin, can be caused by dressings, and as you can see here, this has probably been caused by an irritation of a dressing. Your hyperkeratosis, I'm sure you have all seen hyperkeratotic legs. This is a build-up of that dry skin, and there's an awful lot of dry, flaky skin that you need to be able to remove. Callus formation you often see around diabetic foot ulcers, and then you have your eczema as well. There are further investigations to help you aid diagnosis. So you can do a full blood screen for wounds that are non-healing, and this will help you determine if the patient is anemic, hyperglycemic, or if there's any systemic infection. Your wound swabs for non-healing wounds that have failed to progress or deteriorated with current antimicrobials. This will help determine the pathogen causing the infection along with the relevant sensitive antibiotics. Your ABPI, which is absolutely vital in your leg ulcers, will help determine the arterial perfusion to that lower limb. And then there's pressure perception for your diabetic foot ulceration, and that will help you with your sensory neuropathy. So the National Wound Care Strategy Programme have recommendations for immediate and necessary care. So immediate care is to apply that 20 millimeters of mercury as soon as you see that patient and they have symptoms of venous disease. Now you can't put the immediate and necessary care on, so that 20 millimeters of mercury, if the patient has any of these red flags, so acute infection, symptoms of sepsis, acute or suspected chronic limb-threatening ischemia, suspected acute deep vein thrombosis, suspected skin cancer or bleeding varicose veins. So as long as your patients don't have any of these red flags, then we need to get them into that 20 millimeters of mercury as soon as possible. You then need to arrange for a comprehensive assessment within those 14 days. So within 2 weeks, your patient will need to have a full lower limb assessment and that ABPI, that ankle brachial pressure index, to help us determine whether or not the patient is able to go into 40 millimeters of mercury. So your full assessment within 14 days, suspected venous disease with an adequate arterial supply, you need to refer to the vascular services for diagnosis and intervention and apply strong compression therapy. Suspected venous disease and peripheral arterial disease, if the ABPI is under 0.5, that is an urgent referral to vascular. If the ABPI is over 0.5, you need to refer to vascular services and possibly tissue viability team regarding whether or not to compress these patients. Other uncertain etiologies, you need to refer to your appropriate surfaces. If the ABPI is over 0.8, you can consider the use of strong compression. For lymphedema patients, care should be delivered by clinicians with capabilities to manage that lymphedema. So this is just telling you about your ABPI, your ankle brachial pressure index results. And the ABP provides that index of vessel competency by measuring the ratio of the systolic blood pressure at the ankle and at the arm. And the ABPI values should always be interpreted in context of signs and symptoms. So anything with an ABPI of 0.5 and less suggests severe arterial disease. So compression treatment here is contraindicated and they need an urgent referral to the vascular for vascular assessment. Now, it might be that they do a vascular assessment and the vascular deem that the patient is safe to go into compression, but that will be down to the vascular team to make that decision. If you have an ABPI between 0.8 and 1.3, this suggests that there's no evidence of significant arterial disease and compression can be applied safely for the majority of the people. Greater than 1.3 suggests arterial calcification, so compression may be used with caution, but you need to refer for a vascular assessment. Anything that is greater than 0.5 but less than 0.8 suggests the presence of arterial disease or mixed arterial venous disease. So compression should be avoided, but reduced compression could be used under specialist advice and refer for a vascular assessment. You need to confirm the action plan with your patient. If you open those lines of communication with your patient, you're open and honest with your patient about why they need to have compression therapy, they are more likely to comply with the care that you suggest. But do remember that patients do have a choice in their care. So although they might not agree to having 40 millimeters of mercury, they may agree to having 20, and some compression is better than none. So work with your patient. It might be that they can only tolerate the 20 millimeters of mercury initially, but you might then be able to get them into the 40 millimeters of mercury further down the line. So make sure you work with your patient. So we've done step 1 of our Coloplast 3-step approach. So we've done a really robust holistic and wound assessment of our patient, and we've talked through how we do that. And then we're going to move on to step 2, which is your preparation. So prepare. Clinicians, and I'm sure all of you on this call will have faced challenges that you can see in these pictures below. So your excess fibrin and your slough. So this is a really good picture of a sloughy wound, and you can see that it can look quite fibrous sometimes. Your necrotic tissue and bacteria, so that bioburden that might be in that wound, if we don't reduce the necrotic tissue and the slough that is sat in the wound beds. And then again, your hyperkeratosis, so your surrounding skin, that peri-wound skin, we need to make sure that that is as healthy as it possibly can be to help us move along that healing trajectory. So 80 to 100% of patients with non-healing wounds have biofilm within their wound. And a biofilm is a structured community of microorganisms with genetic diversity that creates chronic infection. Now, biofilms are characterized by significant tolerance to antibiotics and antimicrobials while remaining protected from that host events. Now, I like to think of biofilms as like a little army, and it can be groups of armies that have come together, and that's where the diversity comes from. But they also have little shields that protect them, so they have that extra layer of protection, and that's why often they can be resilient to any antibiotics that we use. So what we need to do to remove some of those shields and get down to that bacteria is wound preparation, and really robust wound preparation to knock off some of those shields and then allow the antimicrobial that we use to penetrate the actual bacteria. So biofilms aren't visible to the eye, but signs of infection indicate presence of biofilm. So you will find that you've got delayed wound healing. There could be increased slough and exudate in that wound. There could be that increased inflammatory response because infected wounds and wounds with biofilms get stuck in that inflammatory response, and we need to be able to move that response on for that healing. Could have erythema, malodor, and a high bacterial load. So the international best practice for management of biofilms and infections, the first step is wound preparation, robust wound preparation. So cleansing and debriding to reduce that number of microorganisms by disturbing and removing some of that biofilm. So as I just said, you need to knock off some of those shields that little army of biofilm are holding. Once we've knocked those off, we can then continue with the other 2 steps. So step 2 and step 3, you would need to think about suppressing your biofilm formation and reducing existing biofilms and microorganisms with an active agent in the dressing. So something like a silver antimicrobial dressing would help to penetrate that bacteria and stop it from multiplying. And then you would need to apply a barrier dressing to prevent that maceration by management of exudate and prevent recontamination. So if you use something like a biotin silicon AG, that is your step 2 and 3 in one dressing. So by cleansing and removing that oh, goodness me, let's start again, get my teeth back in. By cleansing and wound debridement, we can remove those barriers to healing, such as that slough, non-viable tissue, and biofilms. And that's what we need to do. We need to remove everything that is sat in that wound bed that we don't want there, that's going to be a barrier to healing, to be able to move that patient on. So there was a study done by Wilcox and others in 2013, and you might all think, oh, that's quite an old piece of data now. It's 11 years old, but this was looking at the frequency of debridement and time to heal. And it was a cohort study of just over 310,000 wounds. I think it was about 100,000 patients. And what this study looked at, and what you can see on this screen, was they looked at around 50 to 60,000 patients that had diabetic foot ulcers, And what they found was if you debrided or, prepared a wound once every 2 weeks, their median time to heal for diabetic foot was 76 days. If you debrided that wound once a week, that reduced to 21 days healing. So over a third of the time. And I don't know about you, but if I've got a wound, I want my wound to heal in 21 days, not 76 days. So wound preparation really does have its place, and it's a key element to helping our patients to move towards healing. So your holistic assessment directs wound preparation that includes washing, cleansing and debridement. So there are some areas of cleansing and debridement that doesn't require any extended competencies and training. So that's your washing and cleansing of that wound and that lower limb. Autolytic debridement is something that we all do because we all apply dressings, and that helps the autolytic debridement. Autolytic debridement is the body's way of doing what it needs to do to help shed that devitalized tissue by the use of moisture. And if we add a dressing that emphasizes moist wound healing, then that only enhances that body's attempt to shed that devitalized tissue. Mechanical debridement, so this is the physical removal of devitalized tissue using friction. So years gone by, we would use the wet to dry. So this would be wet gauze, put it on the wound, leave it to dry, and then rip it off. I hope you don't see this out in practice anymore. It's excruciatingly painful for your patient, and actually I would say it's abusive. So we now have lovely things like All Prep Pad, which is a mechanical debridement pad to help you debride your wounds in a much friendlier way. You have biological debridement, so that's your use of larvae or maggots, and you also have enzymatic debridement. So this is an ointment or gel that contains enzymes that soften and lifts that necrotic tissue. But you do need to be careful with enzymatic debridement because it can burn any healthy tissue, so you've got to be careful with this. Now, the four blue that you can see here, the autolytic, the mechanical, biological and enzymatic, do not require extended competencies and training, but do require some knowledge and skills. And then you have your conservative, sharp or surgical debridement. So this is where you would use a scalpel, forceps or a curette or scissors to remove any of that devitalized tissue. It may require local or general anaesthetic if this is surgical debridement, depending on the extent of the tissue removal. Now, this is not something that everybody can do. You need to have extended skills and competencies to be able to do conservative sharp debridement. This will probably be your tissue viability nurses that have gone on a sharp debridement course. So please don't all start yielding a knife to your patients. There are plenty of other options, and the mechanical debridement will be one along with the autolytic debridement that a lot of you will be doing on a daily basis. So the National Wound Care Strategy Programme recommends the wound and surrounding skin are cleansed and debridement is considered if required. And as you can see here, we've got All Prep Pad. It's a 2-in-1 device. So you have this dark grey side here, which is for loosening any devitalized tissue in the wound bed. And then you have this lighter grey side here, which is a bit softer with these grey slits. And this is for capturing anything that you have removed. A little hint, if patients find mechanical debridement difficult to tolerate, please give them the pad and ask them to do it. Because what you will find is they'll be able to tolerate a lot more if they do it themselves than if you do it. Just the same as if you squeeze your own spot, you can tolerate that much better if someone else is squeezing it. So how often will wound preparation be required? That really depends on you as the clinician, your clinical assessment, your clinical judgment, your treatment goals and the level of pain of your patients. But if you think back to the Wilcox study that I just showed you, the more that we prepare a wound, the quicker it's going to heal. So I would suggest that every dressing change a wound is prepared, but obviously you need to assess your patient and see if they'll be able to manage that. There are times, of course, that we need to be cautious with wound preparation. So when patients have a wound on the lower limb and it's known is a known diabetic patient, it may be suitable, but we may require that specialist advice. So it may mean that you need to either speak to your diabetic specialist nurses or your tissue viability specialist nurses, or even your vascular specialist nurses if you have them, just to see if they're happy for you to do preparation on that lower limb. If a patient has a known arterial flow concern or poor localized tissue perfusion, we need to be really cautious here, because it means that that area, that wound, isn't getting a blood supply. So if it's got a hard necrosis covering it, we might not decide to do wound preparation, because actually that wound is very unlikely to heal if we can't sort out that arterial flow or that local tissue perfusion. If healing is impaired because of medications or underlying medical conditions, so patients are using cytotoxic medications, they're having treatments for cancer, they're immunosuppressed, we might need to be cautious about wound preparation here, and that is all to do with not opening up these patients to infection. So we've done step one, a robust holistic assessment of your patient and the patient's wound. We've done step two, so wound preparation, ensuring that we're removing those barriers to healing to create that optimum environment for healing. So now we're going to look at step three, which is your treatment. So wound assessment and preparation leads to identification of those objectives for your wound treatment, and we should aim to support an optimum healing environment for the wound. So when you're thinking about your treatment's objectives and you're doing your assessment of your wound, you will be able to see if we need to manage or prevent exudate or exudate pooling, and that means that we need to make sure that we provide a dressing that can manage the exudate adequately, a dressing that perhaps can conform down into the wound bed to help prevent any of that maceration at the wound edge and that peri-wound skin. The protection of that peri-wound skin, maceration or excoriation, your depth or cavity to the wound, and any infection. But you need to remember that identifying and treatment of any underlying causes is integral to wound healing. So if you don't identify the underlying cause of your treatment, or the underlying cause of your patient's wound, the treatment is unlikely to be effective. So you need to make sure that you understand why the patient has this wound. There are various dressings available to us as clinicians, and knowing what each one does is absolutely essential. Commonly used dressings can be broken down into your categories. So we've got our foam categories. So we have biotin silicone in our foam category. We have antimicrobial, so we have biotin silicone AG. We have hydrocolloids, contact layers, gelling fibres, alginates, films, odour absorbers, and hydrogels. And there are an awful lot of dressings on the market that will sit within these categories. So the National Wound Care Strategy Programme recommends the application of a simple, low adherent dressing with sufficient absorbency. Now, as you can see here, this is a biotin silicone dressing with 3D Fit technology. Now, the 3D Fit technology allows the dressing to conform to the wound bed up to 2 centimetres. It absorbs that exudate vertically, so it doesn't allow the exudate to sit on the surrounding skin and the wound edges, and it also locks away 99.98% of bacteria, so it doesn't allow that bacteria to go back into that wound, helping to reduce that infection. So strong compression therapy for suspected venous disease with an adequate arterial supply. So hosiery kits for active ulcers are our go-to, really. So they're a type of medical compression therapy most commonly used for management and healing of venous leg ulceration. The kit consists of 2 medical compression garments designed to be worn one on top of the other. Most kits contain 2 liners and 1 stocking, and they are designed to deliver that 40 millimeters of mercury of pressure at the ankle, reducing to 20 millimeters of mercury at the calf. Now, the recommendation is for it to be worn for 24 hours, but the outer layer may be removed at night if it's more comfortable for the patient. And they are available in off-the-shelf forms or made-to-measure garments if the patient needs a made-to-measure garment. So at Coloplast, our vision is to make life easier for the patient, but also make life easier for you as healthcare professionals. And following the Coloplast three-step approach is a real simplified approach to managing your patient with a wound and moving them towards that healing trajectory. So this is a case study of Mr. H. Now, Mr. H was a 90-year-old gentleman with no other comorbidities. He had a mixed etiology leg ulcer that had been present for more than 10 years. His ABPI stood outside of the normal parameters, so he wasn't suitable for full compression, and he had not been confident to travel since having the wound. Now, all this gentleman wanted to do was go on holiday, and that was our aim, was to get this gentleman on holiday. So our assessment, our management goals, was to create that optimum healing environment by preparing the wound bed, edge, and that peri-wound skin to remove the non-viable tissue, to manage the exudate that was there, to manage the bacterial bioburden, and protect that granulation or epithelial tissue that was present in the wound, and protect that surrounding skin. So we prepared this wound using all-prep pad, and we treated this wound using the Biotane AG non-adhesive. Now, for over more than 10 years, Mr. H had found wound preparation to be too painful to tolerate. Since introducing the all-prep pad, which could be tolerated, his wound made visible and significant progress, as you can see in these pictures here. Mr. H was able to tolerate 10 millimeters of mercury compression, so a liner, and after day 3, which he couldn't have done before due to the pain and the exudate levels that he was experiencing. After managing the infection and the exudate levels with Biotane AG non-adhesive, Mr. H was then able to help share in his care by using Biotane silicone and hosiery, and the wound healed after 54 days of treatment. So again, a very simplified approach, assessment, preparation, and treatment with simplified products. It was 2 products that he used, the Biotane AG non-adhesive, and then his liner. And then he moved on to use the Biotane silicone and his hosiery liner, which meant that he could self-care, self-manage. So I'm going to show you now the Coloplast 3-step approach in clinical practice. Now, we have done, at Coloplast, we have done so far a 60 patient evaluation. This will be a 200 patient evaluation when it's finished, and it is an international evaluation that Denmark are also taking part in. So from the initial 60 patient evaluation, 4 patients were identified to having simple leg ulcers, and 32 patients were identified to have complex leg ulcers. Now, our team of tissue viability nurse specialists defined having a complex leg ulcer as having one or more of the following. They did review all of the literature to be able to come up with this. So to have a complex leg ulcer, the patient had to have one or more of the following. So a wound surface area of 100 centimetres squared, so 10 centimetres by 10 centimetres, a duration of 6 months, a wound that hadn't improved or reduced by 40% within 4 weeks despite following best practice, an abnormal ABPI outside of 0.3 to 1.3 or unable to gain a reading, 0.8, current infection or history of infections, history of non-concordance, an active ulcer with one measurement between 2 and 6 centimetres, and then comorbidities including peripheral arterial disease, diabetes, sickle cell anemia, self-harm, IVDU, rheumatoid arthritis, immunocompromise, and mobility restrictions. So overall, these are the leg ulcer results from these first 60 patients. So the duration of the wounds at the baseline assessment was on average 73.2 weeks. The average wound duration after implementation was only 6.5 weeks. and 79% of those patients healed. So 34 of 43 patients healed in them 6.5 weeks, and 0 patients received any antibiotics during that evaluation period. So this just goes to show you that by following a simplified approach, the Coloplast 3-step approach that you can all follow in your areas of practice, can really reduce the time that that patient spends living with a wound from 73.2 weeks down to 6.5 weeks, just using assessment of the wound, preparation using all-prep pad, and then treatment with 3D fit technology range. And you're, of course, using your compression hosiery garments. The simple leg ulcer results. So these patients had their wounds for an average duration at 8.75 weeks at the baseline assessment. After the implementation of the Coloplast 3-step approach, using assessment, preparation of all-prep pad, and then treatment using 3D fit technology, these wounds healed within 3 weeks. And so there was 4 patients, and 100% of these patients healed, and I think 2 of which actually healed before they even went into any type of compression. Again, none of these patients received any antibiotics during the evaluation period. So that goes to show that the all-prep pad really does help reduce that risk of infection for patients. Your complex leg ulcer results. So the average wound duration at baseline assessment was 39.23 weeks. And after the implementation of the Coloplast 3-step approach, the wound duration was just 6.3 weeks. That's a huge increase for these patients. 91% of those patients have healed. That's 29 of the 32. And again, none of these patients received any antibiotics during the evaluation period. So it's just about implementing a simple approach to wound healing for your patients. The Coloplast 3-step approach does that. It's a simplified approach using assess, prepare, and treat using all-prep pad and 3D fit technology. And again, this is just an overview of your Coloplast 3-step approach. Holistic and wound assessment is paramount to defining those treatment objectives. Your step 2, wound preparation, is key to removing the barriers to healing and creating that optimum healing environment. And then you have step 3, which is your treatment. That simplified portfolio of dressings to manage a wound of any depth and stage of healing. And we use our 3D fit technology. We have a venous leg ulcer pathway, so this is simplifying your wound healing again. So we always start all of our pathways with the triangle of wound assessment. So that's holistic, full holistic assessment of your patient, and then a full holistic assessment of the patient's wound using the wound bed, wound edge, and the peri-wound skin using the triangle of wound assessment. So just to go through this, does the patient have signs of arterial insufficiency? If the patient does, you dress as per local guidelines and refer to a specialist as appropriate. If your patient doesn't have any signs of arterial insufficiency, you need to ask yourself whether you have completed that ABPI, that full lower limb assessment. If you have, and the ABPI is 0.8 to 1.3, then you need to prepare the wound for healing and consider your treatment objectives. So refer to your product selection guide, apply the 40 millimeters of mercury compression, and review frequency as per your local guidelines. If the ABPI is not 0.8 to 1.3, then you need to ask whether the wound is improving. If it is, you would continue the current management and refer to specialists as per your guidelines. If the wound isn't improving, then you review that holistic assessment to optimize factors delaying your healing. You prepare the wound for healing and consider your treatment objectives, and then you would refer to your product selection guide, refer to your local compression guidelines, and refer to a specialist as per local guidelines. If you have not completed your ABPI, you need to prepare your wound for healing and consider your treatment objectives. Refer to your dressing selection guide, apply that mild graduated compression of 20 millimeters of mercury or less at the ankle if the patient has no red flags, and then plan to complete your full ABPI. And of course, you will do your reassessment each time you see your patient. Now, you will all get a copy of this sent to you to help with your practice and following a simplified pathway if you don't have a current one within your local trust. And this is the product selection guide. So again, we always start with step 1, which is assessment of your patient and then of their wound, and you will use the venous leg ulcer pathway here. Step 2 is wound preparation using your All-Pec pad, and step 3 is your treatment. Now, of course, you can use compression hosiery or leg wraps or compression bandaging, depending on which you feel is the most appropriate for your patient. If there are no infections present and you are using compression hosiery or wraps, then you can use the Biotane Silicone or Biotane Silicone Light with the 3D Fit technology, as I described earlier. And this dressing can conform down to up to 2 centimetres, as long as there is no undermining or tunnelling in that wound. If you have compression bandaging, then we would recommend using the Biotane Silicone non-border or the Biotane Silicone non-adhesive to go underneath that compression bandaging. If there are any infections present, using hosiery and leg wraps, we would suggest using the Biotane Silicone AG. Again, this has the 3D Fit technology, but it also has that added bonus of the silver component that has a prolonged release as long as that dressing is intact with that wound. Again, this can conform up to 2 centimetres as long as there is no undermining or tunnelling. If you have compression bandaging in use and an infection present, then you can use the Biotane AG non-adhesive. So for patients experiencing pain with compression hosiery or leg wraps, we do have the Biotane iView, which contains ibuprofen within the dressing, and that can help reduce the pain. And that can be used under compression hosiery, leg wraps, or compression bandaging. Okay, if you've got high levels of exudate, then you may need to consider using Biotane fibre, and you can use the Biotane fibre under the Biotane silicone if you have got undermining or tunnelling, or that wound is greater than 2 centimetres in depth. We also have additional support on our products and services, and we are really excited to announce this is our beautiful Georgia, that we're able to offer you a follow-up telephone call from our specialist team to discuss face-to-face or virtual education with detailed information on our products and services. So you can either scan the QR code that is on the screen now or click on the link in the chat to submit your details. And I believe that Sam will be putting this in the chat for you. And our dedicated team will then aim to give you a call after the event takes place. We also have a coroner's court coming up. So Meet the Coroner, and this is a leg ulcer specific coroner's court case. And this is going to be held on the 12th of June at 2 p.m. And my lovely colleague Sam will be running this coroner's court for you, so you can register again using this QR code that is on the page, or there will be a link that's put into the chat for you to be able to register through. And I hope to see many of you join us at the coroner's court. We will discuss documentation and the importance of documentation, and then we will meet the coroner. So we have a series of videos that have been made by professional actors in a coroner's court, and then we'll have some discussion points in between each video, and they are brilliant sessions. People get lots out of them, so please join us goodness me, please join us if you can. And then finally, we also have a podcast series. It's called Wound Care Conversations. It is available on any of your podcast platforms, such as your Apple, Spotify, Google, Amazon, and lots more. This is a podcast that Sam and I have done, and it helps with education around the Coloplast 3-step approach of assessment, prepare, and treat. We have 5 podcasts that are currently out, and we have another 5 that will be coming soon. So I'd just like to say thank you very much. We've come to the end of the presentation, for joining me today and for listening along with this webinar. I really hope that it has helped you and it will help in the care of your patients with leg ulcers using that Coloplast three-step approach. So Sam, have we got any questions that anybody wants to ask?
There's nothing in the chat. I think that you were brilliant presentation, Charlie. I think you must have answered all the questions that they may have had. We'll stay on here for a couple more minutes in case anyone does have anything they want to ask or want to write in the chat. But very good presentation. Thanks, Charlie.
Brilliant. Thanks ever so much, everyone, for joining us today. Goodbye.